Okay, today we're going to talk about the thoracic chapter. There's some stuff in here that I'm not going to cover that I've added some additional materials on the website that you can use. The mediastinal stuff I did a grand rounds on earlier this year. The PowerPoint for that is in there. All the detail you would need in that is located in that grand rounds PowerPoint. And I encourage you to look over that and then also just read that portion of the chapter on your own. I'm going to try and highlight some of the stuff that I find more relevant for our residency, both as resident on your thoracic or cardiothoracic rotation, as well as for some of the ab site stuff. So hopefully this is helpful and it doesn't take forever. It's a pretty long chapter, so hang in there. So just a little bit about the anatomy. So obviously the thorax is bony. It's between the area of the neck and the abdomen. It's enclosed by the ribs and the sternum and the vertebrae. All right. You got two pleura that cover the lung. That would be the visceral pleura, and the pleura that covers the chest wall would be the parietal pleura. In between them is a potential space. This is a space that we're often familiar with, as this is where fluid can accumulate, air can accumulate, and pus, as well as cancer can occur within the pleuric mesothelioma. You have 12 ribs. It's important to know that there is only 11 rib spaces. It correlates with the rib above it. And there is a neurovascular bundle along each rib that travels along the inferior aspect of each rib, which is why when we're placing chest tubes, we tell you to go up and over the rib so that you're not injuring or damaging the neurovascular bundle associated with it, period. The first rib is kind of important. It's a big, flat rib. It's really difficult to break. If you do have injury to this rib, you're often going to have other associated major trauma, period. So if you're in the trauma bay and they have some, first rib fracture evident on chest x-ray, you can pretty well guarantee that this was a high mechanism of injury, and you need to search for other serious injuries as well. So here's what the bony thorax with some of the underlying structures looks like. Obviously the major vessels in the heart live within the middle portion of the thorax. When you're talking about the musculature of the thorax, I think it's important to recognize both the trapezius and the serratus anterior. Those are going to be muscles that you can use as flaps if you need to cover a stump within the chest wall. These are also how you would either divide or spare when doing a posterior lateral thoracotomy. When you're looking at the anatomy of the lungs proper, there are 3 lobes in the right lung and 2 lobes in the left. You have a major and an oblique fissure on the major or oblique fissure on the right, as well as a minor fissure on the right, and then you have a single fissure on the left lobe. I think this is what probably gets people tripped up a lot. We get tested on this both on ab site as well as when you're in the operating room. Penny, quit freaking out. So you just remember there's 10 segments on the right, and there's really like 8 segments on the left. Some will say 9, some will say 10. It's a little confusing, and there's really not a consensus, but I think overall I would say 10 on the right and 8 or 9 on the left. And then in terms of remembering which lobes have which segments, there is some trouble in remembering, apical, anterior, posterior for the right upper lobe, that kind of thing. And we'll get to that in a second. But in terms of lung anatomy, so gestational, lung development begins around 21 to 28 days. I think we kind of remember from step 1 that your alveolar sacs are surrounded by capillaries at around 7 months, and the proliferation actually continues until after birth, until about 10 years old, where you have about 300 million of them, and then you just have a steady decline of them until death. There's 23 generations of bronchi between the trachea and the terminal alveoli. The bronchopulmonary segments, which are the main ones after the right and left main stem bronchus and bronchus intermedius. Again, there's 10 on the right and 8-ish on the left. There's 5 lobes, 2 on the right, 2 on the left. You have the 2 fissures, like I mentioned, the major one on the right, which separates the lower from the upper and the middle, and then the minor on the right, which separates the upper from the middle lobe. The single oblique fissure on the left separates the upper from the lower lobe. There's also a lingula on the left. It's not technically considered a lobe, I suppose, but it does have lingular bronchopulmonary segments. So when you're looking at these segments, I think it's easy to maybe have a mnemonic for it. I found this one, and sometimes it can be helpful with mnemonics. Sometimes maybe you just remember it. But in order to remember the bronchoforming segments, there's the mnemonic: a palm seed makes another little palm. So that's for your right lung. And then Asia Alps for your left lung. I don't know. This one was something I found. If it works for you, it works for you. Otherwise, it can be difficult to remember. A little bit about the anatomy of the thoracic region. Some of the major players include the phrenic nerve. This is obviously an important nerve. It innervates the diaphragm and is responsible for excursion of the diaphragm and respiration. I think everyone remembers C2, 3, 4, 5 keeps the diaphragm alive. So that's where the level of which an injury can damage the diaphragm or damage the phrenic nerve within the cervical region, but it enters the thoracic inlet on the interior aspect of the anterior scalene. Again, that can be important when you're doing like carotid subclavian bypass. You'll end up seeing this, and then anytime you're operating on the heart, you're going to see that the phrenic nerve kind of runs on the anterior surface of the pericardium as well. The vagus nerve, this enters the thoracic inlet through the carotid sheath, anterior to the subclavian and posterior to the innominate artery. You have recurrent vagus nerves on both the right and the left. On the left is the one I think we're more familiar with, where it travels around the aorta at the level of the ligamentum arteriosum, and on the right it recurs around the innominate artery. Your mediastinum is broken up into 3 sections. You've got your anterior, middle, and your posterior. I think, again, I mentioned the grand rounds that I did on this is posted in the additional information. You can kind of click through that to get a good idea of kind of the major players. We'll talk maybe just touch on that a little bit more at the end, but I'm not going to go into great detail on it. Thoracic duct, one of the 4 or 5 birds of the thorax. This would be the thoracic duct. Don't forget your vagus, your esophagus, and your one other that I'm forgetting. I'll get to you. So, but the thoracic duct originates from the cisterna chyli. It's going to travel up from the abdomen. Once it gets into the thorax, it's going to cross over from the right to the left at approximately the level of the T5, and then it's going to dump on the posterior aspect of the junction between the left internal jugular and the left subclavian vein. Okay, so that's a little bit about the anatomy. I think this is also one of the more important areas when you're talking about thoracic and lung surgery, and how do I know what patient is going to be okay for what surgery? Do they qualify for a pneumonectomy? Do they need a lobectomy? How do I interpret PFTs and incentive spirometry? So I think I'll go over that a little bit in detail here, and hopefully people find that helpful. I'll give a couple of examples. So obviously, when you're going to be doing surgery in the thorax, obviously these are big major surgeries for the most part. You need to assess both their cardiac and their pulmonary function to see if they'll tolerate it. Smoking, no duh, is associated with a huge increased post-op pulmonary complications, and if you can get them to quit smoking for about 8 weeks or more pre-op, you can decrease the amount of post-operative complications. Some things, just like in all surgery, multimodal pain control, early mobilization, early use of incentive spirometer can actually reduce the incidence of pulmonary morbidity. So when you're talking about a physiologic evaluation of the lungs, you want to talk about spirometry and PFTs. So spirometry evaluation measures the mechanical properties of the lung's elasticity, recoil, and compliance. PFTs, or pulmonary function tests, these evaluate gas exchange, and a quantitative VQ scan will give you a status of the functionality of each lung. And we'll go over a little bit an algorithm that kind of looks at what to get what, or when to get each test and who needs what, etc., and how to interpret some of those. DLCO is the diffusion lung capacity, so it's how much, at which rate the molecules move from the alveolar space to combine with hemoglobin. It takes the difference between inspiration and expiration and looks at some values there at the diffusion of carbon monoxide. So what are some good important values to know? straight up, if they've got an FEV1 of greater than 1.5 liters predicted post-op, then they're okay for a lobectomy. If they've got an FEV1 of greater than 2, then they can tolerate a pneumonectomy. And you won't need to get any more studies to further see if they can tolerate what or how much of the lung is actually functioning to provide some of their gas exchange. So the predicted post-op FEV1 of at least 800 mils. If they don't have that number, that's kind of like a magic number that says the need for chronic oxygen post-operatively is likely around there, and the morbidity associated with surgery if you have a predicted post-op FEV1 of less than 800. And then you want a DLCO greater than 50%. So this is a nice little flow chart that I found. I think it can be helpful. So, I think you always want to anticipate that they're going to need more surgery than possible. So if someone has, a right upper lobe and it's near, bronchus intermedius, potentially you're going to be doing maybe, a pneumonectomy or something crazy. So you always want to pretend like they're going to end up with a big one, and that'll tell you if they're going to tolerate that in case you have to do it, or whether or not they'll tolerate the lesser surgery as well. So what's the most extensive surgery likely to be needed for cure? You follow that algorithm down. Maybe it is a lobectomy or a wedge. So you're going to get your bronchodilator spirometer test. If their FEV is greater than 1.5, like I mentioned, yes, great, you're done. You can go ahead and probably operate, notwithstanding their cardiac function testing, and if they'll tolerate it from that standpoint. But strictly from a lung standpoint, yes, they'll be able to tolerate it. No, then you can calculate the estimated postoperative FEV1 by calculating which lobe you're removing, how many segments are in there, and whether or not those segments are contributing to the overall respiratory status. So you can perform a transfer factor, I guess. So you want to know what their sats are on room air. You can calculate their estimated postoperative total lung capacity using the above formula, and then you can express it as a percent predicted from the table of normal values that you get when you get a readout of their PFTs. So they do all this and you get to one of the following. So is their predicted FEV1 less than 40%, but their predicted postoperative TLCO is less than 40%, they're high risk. Any other combination, then you can do some exercise testing. You can have them do a shuttle walk test. If they have an FEV1 predicted post-op of greater than 40%, and they're satting greater than 90% on room air, and their TLCO is greater than 40%, then they're at average risk and you don't need to do anything further. So this is a readout of a PFT. You can see that this patient is a 56-year-old male. He's got an FEV1 predicted of 2.8 liters, and his pre-bronchodilator FEV1 of 2.23 and a post-bronchodilator of 2.26. That's his greatest FEV1 expected, which is 80% of the predicted value, which is obviously way higher than that 40. Okay, so just based on this guy's FEV1, he would qualify for a pneumonectomy. His DLCO is measured as 23.81, which you can see down here. So that's his predicted. So he's actually moving more than his predicted. So obviously greater than 40–50% here. And then this is a what a VQ scan looks like. So this is a patient with a right mass, a right lung mass. Or excuse me, this is a patient with a large left hilar tumor, and they, may have reduced left lung compared with the uninvolved right lung. It's odd because left is on this side and right is on here. Like when you're usually reading, chest X-rays and things like that, it's flipped around. So important to remember that left is left and right is right on these scans. You can see the predicted post-left pneumonectomy right lung function can be obtained here, and we'll go over how to calculate that in a second. So with that last one, you have a left hilar lung tumor, and they need a pneumonectomy. All right, they're predicted from their PFT. Their predicted FEV1 is 2.4 liters. Their pre-bronchodilator is 1.8, and their post-bronchodilator is 1.96. So that's their best expected post-bronchodilator FEV1. Their VQ, so roughly 55% of the right lung and 45% of the left lung. That's a pretty good average, and that's what Dr. Radecki would say when we're kind of going over this stuff in his office on how he would calculate this out. So usually it's about 55% of the right lung is involved in ventilation and perfusion, whereas the left lung does a little bit less. Obviously, the heart's taking up some portion of that cavity, and so you have a little bit less lung mass to use in ventilation and perfusion, and a DLCO of 60%. So you take the right lung, which they're going to remove, all right, 55%, so 0.55 times 1.96 divided by their predicted, which gives you a 44% value. So remember, an FEV1 of greater than 40% predicted post-op after the whatever it is you're removing is adequate risk for surgery and should tolerate it. Let's do another little example here. So you have a right upper lung mass, needs a lobectomy. Remember, Asia palms for the right upper lobe. It has 3 segments, so Asia would be anterior, S superior. Oh, I think I already fucked it up. Anyway, go back. It's, there's 3. Whoops. All right, so anyway, their predicted FEV1 of 2.8 liters. Their FEV1 pre-bronchodilator, not very good, 1.4. Their FEV1 post-dilator, 1.68. So if you were to say, based on just their FEV1, 1.68, that they would tolerate a lobectomy, likely, but not a pneumonectomy. So there's 10 segments in the right, 3 in the right upper lobe. All right, so approximately 55% of that right lung is involved in perfusion. So you take that 55%, you multiply that by their predicted post-op FEV1, their best one, it gives you that much. So 0.924, and that divided by 10, the amount of segments in the right lung, will give you how much each segment is actually contributing to perfusion. So there's 3 in the right upper lung, which gives you this amount. Subtract that from your FEV1, which gives you a predicted post-op FEV1 of 1.4, and then divide that by your expected, your predicted one of 2.8 liters, which gives you a post-op predicted FEV1 of 50%, or 1.4 liters, which again would tolerate a surgery. Hopefully that's helpful. You can do a couple random examples on your own if you need to, but I think it's a good way to identify kind of, is this patient going to tolerate it? Okay, let's talk a little bit about thoracic incisions. So you can do anterior, posterior, or axillary thoracotomies, obviously depending on what structures and part of the thorax you're trying to get to. You can do a muscle sparing, or you can do a non-muscle sparing. You typically will enter the 5th or 4th intercostal spaces. You can do a median sternotomy or a clamshell. So here's the left anterior lateral thoracotomy. This is usually the ED thoracotomy. This is what you're going to do in the trauma bay for an unstable patient. You're going to go with the inframammary fold, and you're going to go pretty much midline from the sternum all the way down towards the axilla, all the way to the bed with a knife. Get some scissors in there, cut through the pleura, and then you'll do whatever it is you need to do. Again, you're trying to get to that 4th or 5th intercostal space. It should not be a straight line, and you obviously don't want to cut through breast tissue on the woman. But this can give you exposure of the heart, the aorta, the left lung with the hilum, and you can always extend this to the other side to make it a clamshell. So here, you clamshell this out. I've never actually seen this, but this is usually for like a transmediastinal gunshot wound. Most of the time, obviously extended from your left. It's going to give you exposure to now the aorta, the right lung, and the descending aorta, the hilum. Again, you don't want to cut through female breast tissue, so you can, if possible, I guess, draw the breast up or bring the breast down. Median sternotomy. This can take a little bit longer. It can be done fairly quickly, obviously, if you have the saw or the Lischke blade. I can remember a couple of experiences in the trauma bay where a Lischke blade was utilized. It's preferred in superior mediastinum hematomas, precordial stab wounds. You can take control of proximal subclavian vessels or the aortic arch, and you may be able to extend this up into the neck for part of your thoracolaparotomy. This is your more traditional posterior lateral thoracotomy that you're going to be doing for lung cancers and, thoracotomies in the OR for lung procedures or mediastinal procedures. It's going to give you a good aspect to the posterior mediastinum. And again, this is what we use for our esophageal resections as well. So when you talk about a muscle-sparing thoracotomy and what muscles are you sparing, these are some of your options for which incision you can do to create your muscle sparing. Generally what you'll do is you'll kind of roll your fingers over the latissimus dorsi on their body before you make your incision and kind of mark out where that area is. And you'll make your incision just anterior to that in a vertical fashion. You'll separate lateral serratus and then your end of the chest via the fourth and fifth intercostal space. So this is your incision, and then by retracting the muscle back this way and serratus this way, you can then get into the lung space through the intercostal space here. Not uncommonly, actually, with Dr. Radecki, would you resect a little portion of the rib in order to get better exposure. All right, so let's talk about some of the congenital lung lesions. So Tyler gave a podcast on pediatric surgery, and you'll do a couple of months of pediatric surgery. You'll see a little bit of thoracic while you're there, not a ton. You won't see cardio stuff or cardiac surgery, but you may see some lung surgery. I'm not going to go into great detail on this, but some of the ones that you need to know about, you've got your congenital diaphragmatic hernias. This is your botchdolec back and to the left, as well as your Morgagni. These are associated with some significant lung hypoplasia. Oftentimes these patients, you're aware of it prior to the delivery, and they can go straight from there to ECMO, and then other procedures, fix the hernia, etc. Other causes of this can be oligohydramnios, prune belly syndrome, and scimitar syndrome. I'll touch a little bit on those a little bit later. And then hyaline membrane disease, which is infantry version of ARDS. These are premature babies who have less than 24 weeks gestational age. They haven't created enough surfactant to allow for the alveoli to smoothly interact in gas exchange, and a pretty high mortality. 10 to 30% of these infants will not survive. Some cystic lesions. So this is the result of separation of the pulmonary remnants from the airway branchings. Usually you can just treat this with antibiotics. If it is recurrent infections or concern for a malignancy, then you would go ahead and obviously resect this. Bronchogenic cysts. Excuse me. These arise from a tracheal bronchial diverticulum. It's frequently an incidental finding on chest x-ray, and 10% of these mediastinal masses in children will be bronchogenic cysts. The treatment is to excise these to confirm the diagnosis and rule out malignancy. You can get congenital bronchopulmonary malformations. So lobar emphysema, this is the most common resected congenital cystic lesion. It affects the upper lobes predominantly. It's usually due to bronchiolitis. And then you can also have congenital cystic adenomatoid malformations, which is going to be the second most commonly resected lesion. I would encourage you to look up some chest x-rays that have these on there, as you may in ABSITE occasionally get a picture of one of these and be asked to identify what it is. Pulmonary sequestration, I think this is kind of interesting. Also something that I have seen on ABSITE before. I don't think I saw it this last year, but it does pop up every so often. So this is an area of embryonic lung tissue, a separate lung bud that that separates from the lung, but continues to receive blood supply from an anomalous systemic artery off the aorta. And then this accessory lung bud can either be interlobar or extralobar. If it's an extralobar sequestration, these usually develop a little bit later. It's about 25%. Most of these are intralobar. These are primarily going to be on the left side, and they are completely enclosed by their own pleura. They look like a separate little lung right there. And the blood supply is usually from the thoracic or upper abdominal aorta to the systemic veins. And then you need to make sure that obviously you resect these. The intralobar sequestrations, these are usually in the lower lobes, and they're evenly distributed between the right and left lungs. The blood supply is from the descending thoracic aorta, and it transverses the pulmonary ligament. And then it gets its venous drainage via the pulmonary veins, which is unique to the intralobar. Esophageal atresia and tracheoesophageal fistulas. Again, Tyler goes over some of that stuff, so refer to the pediatric lectures for that. Tracheomalacia. This is collapse of greater than half of the lumen during expiration. So you can see this on bronchoscopy. The respirations can be intermittently difficult, or it can be so severe that they require stent placement or some sort of tracheobronchoplasty in adults. Some congenital vascular disorder, so scimitar I mentioned earlier, this can be one of the causes of a bronchopulmonary dysplasia. You get drainage of the pulmonary vein into the IVC. I guess the treatment of this is ECMO, and then you patch from the pulmonary vein to the left atrium via an atrioseptal defect. So pretty cool stuff, but definitely not something we're ever going to be seeing or doing. You can get these pulmonary AV malformations if you see someone with a hemoptysis without a lung mass that's obviously causing it, or recent infection. This is commonly associated with Osler-Weber-Rendow syndrome, or I think it's also known as hereditary hemangiotelangiectasia disorder, something like that. I think these guys were all Nazis, so they stopped using that name really. Anyway, the treatment for this is if they're symptomatic with hemoptysis, then you can either resect that portion that has the AV malformation, or you can do a catheter-directed embolization of the AV malformation. You can get these pulmonary vascular slings. This is usually an anomalous or an aberrant left pulmonary artery that's causing an airway obstruction. It's going to go from the right main pulmonary artery, and it's going to go between the trachea and the esophagus to supply the left lung. And obviously this requires some sort of reconstructive surgery as it's causing the airway obstruction. Okay, so that's kind of the brief overview of some of the congenital disorders. Lung cancer, it's obviously a huge topic. It's something that you're going to be operating on your thoracic rotation. It's something that you're going to get tested on, and it's something that all your patients are likely going to, have questions about if they're smokers, and if you need to refer them for solitary pulmonary nodules, etc. There's just a wide range of lung cancer and how it affects a variety of different practices. So 221,000 new cases in 2015. It's the most frequent cause of death for cancer in both men and women. It's 13% of all cancer diagnoses, and it's 27% of all cancer deaths. So clearly it portends a poor prognosis, as a lot of these are caught pretty late. You'll see a little bit later, and the survival is not very good. It exceeds the combined total deaths from breast, prostate, and colorectal combined. And then obviously cigarette smoking is your greatest risk factor. Some other risk factors are environmental. Radon is the second most common cause, and then there's a big radon issue here in Ohio. In Oregon, we don't have basements very often, and so I was unfamiliar with the radon, systems that you have to have here in Ohio that kind of can accumulate in your basements. So if you don't have a radon detector,